Manitoba, we've had studies in the past year that have indicated that we are going to need thousands more nursing home spaces, beds, in the coming 2 decades or so. Are these studies are showing that there's this amount of spaces needed? Are those numbers carved in stone, or do you think that there's perhaps some alternatives that society might be able to come up with that would lessen that demand? Malcolm?
Okay, so most provinces in Canada are dealing with a similar issue. In Manitoba, it's tough to double the number of 75-plus-year-olds, the major users of nursing homes in the next 25 years, and not need more of something. The question that everyone is grappling with, I think, is how much more, what, and by when. And so we've done some projections on nursing homes that that a number of beds that you need depends upon some assumptions that you make, and it is possible to deal with this not just with nursing homes but with other types of community-based care to some extent.
What would be some of those examples?
Well, Manitoba has, through its aging in place format, it has supportive housing. So supportive housing is there typically for people that need 24-hour support, but not necessarily 24-hour hands-on supervision. So people that need a little bit of assistance with activities of daily living, like getting dressed and being mobile, maybe have some cognitive challenges, but nothing that severe.
Trudy, what's the situation in the United States? I take it there you have the same aging demographic. What is the demand for nursing homes there, and what are the alternatives that are offered?
Well, obviously we have the same problem, as do many other European countries. We're facing aging populations. People are living longer. The technology makes it possible for people to live longer, but that doesn't mean that they can always have the same kind of quality of life they had when they were younger. So what's happening in the U.S. is that we really do have a lot of nursing homes, which is the highest level of care for some of the most seriously ill, complex patients. And I know that's exactly the same situation here in Manitoba. So the people going into those facilities are really sick. They have a very high acuity level, and that's jargon for saying that they are really sick people. And they need a lot of care. But that said, the preferred place of care in the U.S., and I'm sure in this country as well as every other country, is not in a nursing home. That is the last place you want to go. So people really want to stay in the home and kind of age in place to the extent they can. So, and the families want that. It's a cheaper kind of care to the healthcare system, whether it's paid for publicly, as it is largely in your country, or privately, as it is in ours. We do have some public funding of long-term care services. And what that means is that those community supports need to be there. We need to have a lot of home and community-based care. That's what we call it, home and community-based care. That's sort of the academic jargon for it. But what it really means is a smorgasbord of services that allow someone to remain in their home and age in place as long as they can. And that includes meals, it includes transportation to doctors, it includes people to come in and turn a light bulb on or repair, change the light bulb in your apartment, shovel your snow, that kind of service, as well as supportive care, some kinds of lower level physical care that you need. And what we're finding in the U.S. is that we don't really have enough of those in various communities.
So there is a system in place to help people live at home, prevent them from going to a nursing home, but those services are not uniform, or they're not as those services aren't as prevalent as people would like.
They're not as available. I mean, you talk about waiting lists in Canada, waiting for various kinds of high-tech elective procedures like hip replacements. We have a lot of waiting lists in our country for those very in-home supportive services. And what we have that is good is that we have a law in place called the Older Americans Act. And this law was passed in the 1960s when Congress contemplated an aging population and felt that there needed to be help for this group that's going to age pretty rapidly. And so that law was passed, and then the meal programs under that law were passed in the early 1970s. So we have the structure in place, and it's being, we have an administration on aging, we have area agencies on aging where the money gets funneled, and then the service is kind of put in place through these structures called the area agencies on aging. But the problem, what we've had over the last 30 years or so, is that those programs have been woefully underfunded. And Congress has not seen fit to appropriate the kind of money that is needed to keep people aging in place in home in the community. So what we have now, because we've had all this budget discussion going on now for so many years and efforts to shrink the budget as much as we can, those programs under the Older Americans Act have definitely been cut or flatlined, which of course is equivalent to a cut. They're really not growing. And so this is what's causing a lot of the shortages. And then we also have another thing called the Medicaid waiver. Now, Medicaid is one of our public health insurance systems. It is a joint federally funded, state-funded program. Each state has a Medicaid program. And Medicaid pays for about 50% of all nursing home stays in the United States. And the way that's done is through what we call a spend down. Since Medicaid is a program for poor people, and that's how some poor people get health care, you can make yourself poor and become eligible for help paying for nursing home care if you make yourself poor, and we call that spending down to Medicaid, which means that a family has to use up all of their income and virtually all of their assets before Medicaid will step in and pay. And of course, the problem that we've encountered over the years is that the spouse who remains in the community is often disadvantaged because he or she doesn't have enough to live on. So Medicaid will pay, but there's been a big effort in the U.S. to try to keep people out of the nursing home if you can, at least on the one hand. They're trying to do that through these waiver programs. And each state has so many waivers that they can get. So if a person is eligible for home care in the community, they can get a waiver. But there's one really big catch. There aren't very many of them around, and lots of people want them. So fairly recently, I was in Baltimore, Maryland, interviewing a gentleman who was in his high 80s, and he was number 13,146 on a list for a Medicaid waiver that would provide in-home supports, some health care that he needed on a daily basis, a little bit of companionship, and home-delivered meals. But he was not going to get these services because he's clearly going to a nursing home before he gets services in the home.
That's very interesting, and I'd like to, Malcolm, if you could describe some of the services, home care services.
Bit of a compare and contrast.
Yes.
So
Available in Manitoba.
In lots of instances, the comments that I'll make mirror what you've been said, but I also think there's some very important distinctions. So in Manitoba, or in Winnipeg, if you will, we do have a single entry system. So let me back up. So in healthcare writ large, our healthcare, the majority of it is controlled under the Canada Health Act, right? Mm-hmm. So that's a physician hospital acute care system. So, for example, nothing stopping me from going to see my primary care provider or the ER every day if I want to, and I don't pay directly for that. So those are universal services, right? Mm-hmm. Technically, anyways. And so. However, when I go outside of those acute care systems into home care, just because I ask for home care doesn't mean I get it, right? So we have a case coordinator. If my physician or a family member or someone decided that I needed home care, case coordinator would come and see me, usually in my home if possible, and they would look at my needs, my environment, and make some decisions, right? They would say, okay, Malcolm needs far more than home care, so we're going to bypass the home care and go into a nursing home or a personal care home, as they're called in Manitoba. Or they would say, yes, Malcolm can get these types of home care services to try and enable him to live successfully in his community. At some point, as you move along that continuum, the decision is made, I think, really on two factors. One is it's not safe for me to live in the community alone anymore. I've left the stove on or what have you numerous times. Or the basket of services that are provided by home care in the long run perhaps isn't efficient anymore, right? It's too costly. So then the discussion, usually by the same case coordinator, is, well, what's next? And so Manitoba, all provinces have something similar to this, has implemented as our continuum of care used to be home care and then nursing homes. Now it's home care, a basket of other services, but the big one is supportive housing and then nursing homes. So, supportive housing is meant to be an alternate or a different option for nursing homes.
Just backing you up there for
Yeah.
a second, Malcolm, Trudy was talking about the difficulty sometimes in getting some of these services in parts of the United States.
Yeah.
How easy is it? Is there
Yeah.
Sufficient capacity in
Great
for home
question.
care?
I mean, if you talk to the home care people, they'd say no, right? And I think a thing to keep in mind is never mind quality of care. If you look at cost of care, it's there's lots of research out that says the per diem cost to provide home care is quite small compared to supportive housing, compared to a nursing home, compared to hospitals. So from a cost point of view, it's much cheaper to have a person remain in their home. I don't think, although I can't say for certain that there's huge lineups for home care and wait lists for home care in terms
capacity
of
is
it's
there
there.
largely.
Usually, once a decision is made to give a person home care, it's there in the fairly immediate future. That's much less the case for nursing homes, for example, where there are instances where there are people waiting in the community for a nursing home for upwards of a year. Hospitals, not as long as that for the majority of cases, but upwards of 30 to 60 days sometimes waiting to get in to a nursing home. So it depends a little bit on where you're coming from.
Let's talk about nursing homes and the types of clients that they're designed to help, and how maybe that's changed over the years. I know I've heard the anecdote that in the 70s in Manitoba, when nursing homes came about, that one of the big issues among residents was the availability of resident parking. That's changed, I take
Yes.
it. Can you talk, Malcolm, a bit about how
Sure.
the type of client has evolved since then in nursing homes?
Right.
And,
So one of the big things I think that decision makers are grappling with is what's the minimal amount of needs that a nursing home resident should have, right? And if it's going to be here, then where are these people going to go? But if it's going to be here, then where does this basket of people go, right? Those types of things. So 1985-ish to now, there's lots of evidence around that says that people are going into nursing homes much later in life. They're staying for a much shorter period of time and leaving usually by of death. And the number of needs that they have or their level of sickness is much greater. We've just done some research that's not just looking at this type of a sickness of a person, but trying to sort out, well, how many people are bowel incontinent multiple times a week? How many people need weight-bearing help for their activities of daily living, like being mobile or getting out of bed? How many people have challenges with their behavior on a frequent basis that can't be resolved? How many people have challenges with dementia and whatnot? But then the other question is, how many people have major challenges in multiple sections of those areas, and it's not 5%. It varies by facility quite substantially, but it's upwards of 60% of residents at some point during their stay will have high needs in multiple areas. So it's a very, very complex care environment compared to what it was, I would say, in the past.
And Trudy, in the United States, have you seen similar evolution of the type of client, or what is the situation there?
Well, we have a saying in the U.S. that they're discharged from the hospital quicker and sicker. And because of our payment system that was changed about 30 years ago, hospitals are paid on it's called a DRG, diagnostic related group. And so they are getting one payment for people who come into the hospital and have the same kind of illnesses, the same kind of services. And so they get that DRG, and if somebody needs to stay longer and exceeds what the hospital is going to get paid, there's a great incentive for them to get that person out and into the community or the nursing home. And typically what happens, because we don't have any single entry point, it's kind of a big mess to get a resident, your family member I should say, assessed and into the right placement. Often that doesn't happen, because typically what happens is a discharge planner says, you know, you've got to get grandpa out of here tomorrow or 2 days from now or whatever it is. So the family sits down with the social worker at the hospital who's working for the hospital, and she needs to get this patient out fast because the hospital is going to lose money if they don't. So the daughter-in-law sits there and says, what do I do? So she often gives them some phone numbers to call, the area agency on aging, or maybe a nursing home group, or maybe the long-term ombudsman. We have an ombudsman system. Every state has a long-term ombudsman, and locales have little ombudsmen. And they're fairly effective. Some of them are quite good. Others are really afraid of the nursing home industry, and they're not quite so forthcoming. But anyway, they might provide some help. But basically, it's up to the daughter, usually, or the daughter-in-law, to take this on. And without the single entry point, and as you have in a couple of provinces in Canada, it has amazed me how people really sort of cut through that morass without very much help. So often people don't end up in the right spot for them, because if you can take somebody home and then on your own have to put together this whole package of services to keep them in the home, just think of how difficult that is. And then how difficult is it then to find how you're going to pay for these services? Most people don't have money to pay for them. Home care is very expensive. It's privately done. Home care workers might, at least they used to charge, $70, $80, $90 a day. I think it's probably more now. And then to consider the quality of the care you're going to get in these various settings. So it's a very daunting task, and I think that sometimes family members do not end up in the right spot, and maybe many of them do go to nursing homes because at least, you know, there's some place. And then the family has this shot at getting some sort of state help if they make themselves poor enough and spend down to Medicaid. And often we find families start out paying privately in a nursing home, but if the stay lasts a long time, they run out of money, and they do spend down to the Medicaid level in order to get the state to pay for it.
So in the United States, there's a lot of onus on the, or a lot of responsibility for a family member to find the home care, if that's the option, or even to pick from several different private providers for nursing homes.
Or to choose a nursing home, I mean, which is not easy. I mean, when I, in a former career capacity, I rated a lot of nursing homes. Evaluated these for Consumer Reports magazine, and we looked at a lot of nursing homes and devised ways that people could evaluate a nursing home. And ironically, in our system, nursing homes are some of the best regulated entities in the United States for obvious reasons. They're dealing with very sick people. And the law, the regulating law, goes back to 1987, passed in the Reagan administration. The problem is it's not very well enforced for a lot of political reasons. So as part of that regulatory structure, they have to pass some inspections, and often they have a lot of problems. But all this is public, and all these reports are available to the public. They must be posted prominently in the nursing home. So if you have not done very well on your state survey, which is done every 12 to 15 months, that result is out there for people to see. But too often, what I have found in my investigations is that the nursing home hides that document. And they put it under magazines in the waiting room. They put it really high up in the cafeteria or in the dining room this way so nobody can read it. And I was in New Orleans once and came across a nursing home that said that they used to have a state survey, but a resident ate it. So I have come up with encountered all kinds of reasons why it's not there. But fortunately, an abbreviated version of that is now being made available by the Centers for Medicare and Medicaid Services. So families and journalists can get some information from that. I would argue there's no substitute for going in and looking for the actual survey in the nursing home. But just imagine if you're looking at 3 different facilities going around, but you're going to have to do this because you're going to have to walk through the facility, go at different times of the day, look at the activities, see if that's where you want to put mom. And it's tough.
Right, and Malcolm, in Manitoba, if you need home care, someone gives you an assessment, and that will, if you meet those that assessment level, then you receive it, and there's not a big waiting list generally. And with personal care homes or nursing homes, if again it's a central, it's a panel or a couple of people who make that decision based on whether they feel that your disabilities or illnesses require that you go to one.
Sure.
But really, though, that decision of trying, or that search for a facility or comparing, that's taken out of your hands. You may have a preference of which home you'd like to go to, but you won't necessarily go there right away, right?
Right. So there's 2 pieces to this, and again, a bit of a compare and a contrast. I want to back up for a second.
Sure.
I think that we're lucky in Manitoba for a couple of reasons. One is, we're talking about this piece of the healthcare system, and the healthcare system is like a big water balloon. You poke it in one spot, and something comes out in another area, and it's all tied together.
Right.
Right. And so, if you think of the healthcare system at large, Manitoba has come out and said, well, let's prioritize some things that need to be addressed in healthcare delivery, and this whole continuum of care for the older adult has made the top 4. So, I'd like to say that our decision makers are trying to make a conscientious effort to go, what needs to happen here and how do we do this best? The problem is this is very complicated, right? And I think everyone is struggling a little bit with, well, how do we go about addressing this? But I think the base is there, right? So that's the first statement that I would make. It's not without problems by any stretch of the imagination. Yes, there are waiting lists for personal care homes or nursing homes. The environment is very different in large urban areas versus rural areas. Rural areas are you look at hospitals and how full those hospitals are of people that are waiting to get in to the nursing homes. A very, very tricky situation. The one piece that is a little bit similar for this is I think there's 2 things that need to happen in terms of moving the ball forward. We're talking about what's happening in Manitoba, and a lot of the things that happen in other provinces are at the base similar to that. But there are provinces that are also have approached this very, very differently. So, for example, Winnipeg has about 125 nursing home beds per 1,000 population, 75 plus, and sorry, not Winnipeg, Manitoba has that.
Right.
But yet as a province, we're feeling the squeeze. If you look at BC, I think they have 75 beds per, and so they're approaching 2/3 capacity of what we have. And you know, I think it's a very logical question to say, what are our neighbors doing, and are they in far more trouble than we're in, or have they devised something else that we can look for and to learn some lessons from? So that's a big one, I think.
And have they learned
I
some lessons?
don't know, to be honest with you. I would say not to the capacity that could be done. I think there needs to be a sit-down, earnest conversation to say what has happened here. We're talking about supportive housing in Manitoba. They have one level of supportive housing. Alberta, I think, has 4 levels of supportive housing.
And by supportive housing, this is a level of care that is not quite as serious.
Yes, lighter level care.
It's not. It doesn't feel like an institution when you
Yes.
go into
Yes,
it.
yeah, it's in the community. The one piece I think that has a lot, or is starting to approach on some similarities with what you were saying, is this whole piece of the money, right? So I don't pay for home care, right, out of my own pocket.
That's insured.
Yeah, if I do go into a nursing home, I pay a per diem, and between $24 and $75-ish a day, pending my net income and marital status and those types of things. But my drugs are covered, and I got a roof over my head, and I get 3 meals a day, et cetera, et cetera. When you go into supportive housing, there's a bit of a different payment structure. So there's a rent component, there's a services component. You pay for your drugs until our provincial insurance system kicks in. There's a few other, and so the question becomes, well, how much have we set this up so that we're going based on need versus ability to pay? And I don't know that but it's an issue that needs to be looked at, I think, to help streamline this process a little more, which gets at a little bit of some of the things that you're talking about.
To make sure that the right people are going to the right places for the right reasons.
Yes, at the right time. Yeah.
Okay, that to me that brings up the whole notion of what is the quality of nursing homes. First in the United States, I know it's a big country. It's quite a blanket question, but can you? It's a private system, privately delivered system.
For the most part.
What is the quality like in various parts of the United States?
Not very good. I have done many exposés on nursing homes. My colleagues in the media have done this since Medicaid came in 1965 and began paying for nursing home care. When I first moved to New York, there were big exposés about poor quality care in the New York Times, and that was in the 1970s. And there's been a whole parade of really good reporting on poor quality nursing homes. And, you know, in the last couple of years, there have been lots of really good stories being done. And nothing really seems to change. The story is always the same. The quality of care for many nursing homes is not very good, as evidenced by all the inspection reports and just general observation. I have witnessed a lot of poor quality care just by walking in saying I'm looking for a place for my mother. That's part of my repertorial technique. And so what I have found is what other reporters have found, and it just doesn't seem to change. So the question really is why? We have a really good law in place. It's really not enforced. And it really comes down to the quality and the power of the nursing home industry. They're very strong in the states. They have a very strong lobbying presence in every state and in Washington. And a lot of dollars are being diverted to nursing home care, when some people are asking maybe some of those dollars should be better spent in the community. And in the meantime, you have to question the quality of care that's being delivered. Now, that's not to say there aren't good nursing homes. I have seen a few, and they've been quite good, actually. But they are really in the minority. And you sort of ask yourself, after the end of some of these very long projects, why?
So the responsibility for inspecting nursing homes, is that at a state level?
The federal government has the responsibility, but the states carry out the inspections. So what's happened, and they do this every 12 to 15 months, and usually the facilities know when they're coming and they kind of spruce up the
So there's
place.
warnings.
Oh yeah, they sort of know. I mean, they don't get an announcement, but they know when the inspectors are coming. And so what happens is that the states often don't have enough inspectors because budgets have been cut in the states. There's pressure on the surveyors, the state surveyor, to go easy on the industry and to write the deficiencies, we call them, at very low levels of scope and severity so that they don't get challenged. And if you write them at a higher level of scope and severity, the nursing home is more likely to challenge the state. The state doesn't have the money to defend an administrative procedure going all the way through the courts. And of course, there's all kinds of appeal rights that a facility has. And what happens is that sometimes the states negotiate a lower penalty. They all can levy fines. And we did studies about how these fines were. They were so low as to be ridiculous. And they get reduced. So the facility says, I'll take a lower penalty and promise not to sue you. So that's how it's done.
Malcolm, what about the quality of Manitoba nursing homes, and who's making sure that these facilities are operating the way they should?
Yeah.
Or what's the oversight, I guess?
Okay, so again, a little bit different, well, actually a fair amount different in this instance between Manitoba at least and the U.S. is the province is the oversight body. Yes, we have regular inspections. I think on average that most facilities are seen, I want to say once every 18 months at minimum.
Mm-hmm.
And the inspection processes are a combination of, hey Trudy, I'm going to be at your site next week, so some of that.
Mm-hmm.
But also in combination of that is, hi, we're here. Right? So there's a combination of surprise,
Unannounced visits,
announced
yes.
and
Mhm.
unannounced, right? And they have a whole variety of inspection points that you look at. And if a facility, passes with flying colors versus has problems in one area versus problems in multiple areas, that dictates on how frequently they're visited again. So on the surface, there's a very good inspection plan in terms of, announced versus unannounced and frequency.
As for quality?
Quality. Now, quality, variation is the word that comes to mind there. But also I want to say that let's not forget the first comment that we talked around complexity of care, that these are very sick people. So, one of the things so we've done a fair amount of research on this, and so looking at, well, how frequently do pressure sores or restraint use or drugs that shouldn't be prescribed to older, how often does that occur? And so there's facilities that it doesn't occur very often, right, at all. And there are facilities, if you look at 15 indicators, they're in the highest 10% for 7 or 8 of those, right? So are there trends in terms of what those facilities look like? For-profit facilities tend to, writ large, get a bad rap in terms of quality care. If you look at on average, yes, that happens. Does it mean that there's not good examples of very good quality care in for-profit nursing homes? Yes, of course it means that. There's good examples as well. The one other thing that, again, Trudy, that you spoke of is the public awareness of all of this and the ability of the public to go in and look at quality care. And that's one thing that we are behind in
It's very
Manitoba.
difficult.
Yes, and however, having said that, there was a white paper put out a little bit ago that made the call to be like this. So at the Center for Health Policy, we're actually in a process right now where we've sat down with a large number of directors of care and providers, etc., and said, here's a list of 40 indicators. Which of these do you think it's fair to be tested on? Right? Should we test you on something that's not sensitive to change and rarely happens and isn't a big deal? Let's pick things that are really, that you can do something about readily, that happens a lot and really negatively impacts the residents. So we've just decided on 15 of those, so we're just starting around the process to do something that you folks have already done, to build websites so that the public can go in and say, oh, I want to send, my mother or father, whatever, to this site. Here's what it looks like, et cetera, et cetera.
Okay. Before we wrap up, I'd like to ask each of you, we've been talking about an aging population and some of the challenges that'll present. Malcolm, first, what do we need to know more about as we move forward?
I think the thing we need to know the most of, and it's a bit of a repeat of what I've said, I think we can get to some of it by looking at our neighbors in terms of what they've done, but I think we really need to understand how to transition people better, right? What's the basket of long-term care services that we need? How many of them do we need? What type of person could be successful in those environments, and for how long, versus just saying we need more institutional care.
Right. So in between the time where you might be at home as a senior receiving some home care support, there are probably different types of facilities that you may live in without going to a nursing home.
Right. So I mean, the word proactive comes to mind, right? And I think this is the whole piece around getting someone at the right place at the right time is to get them so they can continue to be mobile and enjoy their life and be active to the maximum amount of their ability to kind of hold them at that for as long as possible.
Right. My sense that we're at a very early stages in Manitoba of developing some of those alternatives. It's still very much, either you're in your home or you're looked at for a personal care home. There are other facilities, but there aren't as many of those facilities.
So supportive housing, I think, is a major step forward in Manitoba, or at least in Winnipeg. I think that there is potentially some very big value in looking at some of our neighbors, especially Alberta and BC, and saying they have a much larger basket of those services. What do they look like, and how many people that are currently in nursing homes or personal care homes could relish in those other environments?
Trudy, what do we need to know more about and when it comes to this topic?
Well, I think we really have to do a better job and know more about how to do transitions without having mistakes all along the way. What we find is that a lot of medical errors occur in the transfer process as people move from one kind of care setting to another, whether that's the acute care hospital to a nursing home back to the acute care hospital, or to a personal care home, which has a very different meaning in the U.S., or to their own home or their daughter's home or whatever. And I think that's where we have a lot of medical errors, a lot of medicine errors occur at these points. And I think that's being studied in the U.S. There's a lot of talk about making those transitions more seamless, but I think we have a ways to go.
Thank you.
Okay, thank you.